Hello everyone. Today we will cover valvular heart disease. Valve pathologies can be broadly divided into stenosis or insufficiency or regurgitation. And then uh, first we have aortic stenosis, which is common and seen in the elderly most often. Um, by definition, aortic stenosis is the narrowing of the aortic valve. This causes obstruction to the outflow from the left ventricle during systole. Common causes of aortic stenosis include calcific degeneration that's present in the elderly, congenital bicuspid valve, rheumatic disease rarely, mechanism or pathophysiology. The valve area decreases. This increases the pressure gradient across the valve, and the left ventricle has to push against more pressure. This can over time dilate the left ventricle, cause heart failure, etc. Um, Hemodynamically becomes significant if the valve area becomes less than 1.0 centimeter. Usually, if the valve area is more than 1.0 centimeter, patients may not experience many symptoms. Um, Now, pathophysiology in the early stages, the stenotic valve causes overload, which is pressure overload on the left ventricle. It hypertrophies, gets concentric hypertrophy. Ejection fraction stays normal. Cavity size remains normal for a while. Compensation happens. The heart has to contract with increased contractility force. This force or this increased contractility maintains forward flow despite there being stenosis. Sometimes patients like this can decompensate. Left ventricle gets exhausted, it gets dilated, and they present with acute decompensated heart failure, reduced ejection fraction, pulmonary congestion, etc. Now, sometimes severe aortic stenosis, it may have low pressure gradient, but ejection fraction could be reduced. This would indicate that the disease is very advanced. Uh, Clinically, you would see patients getting exertional chest pain, syncope, dyspnea, signs of heart failure. On physical exam, you will see pulsus parvus ictardis or weak delayed pulses. Um, Pulse pressure will come down. The difference between systolic and diastolic blood pressure would be narrowed or will come down. On auscultation, you will hear systolic ejection murmur, or we also hear this other murmur, or we can also say that this murmur represents as a crescendo, meaning goes up in intensity and then comes down crescendo, decrescendo murmur at the second intercostal space on the right, and it radiates to the carotids. The A2 sound or aortic sound may be soft or absent in aortic stenosis. Patients who are asymptomatic, aortic stenosis may be found by incidental echo, or once we find it by accident or by incident, we do exercise testing to see what we need to do further. Investigations on ECG, you would see left ventricular hypertrophy, and you may see strain pattern or the left ventricular strain pattern. Chest X-ray, you may see the aorta is dilated after the stenosis. Echo is gold standard for valvular diseases. It will give us aortic valve area. We can see the pressure gradients. We can see the left ventricle's function on echo. Now, based on echo, then we can divide it into severity. Severe aortic valve disease is area equal to or less than 1 centimeter square, or pressure gradient equal to or more than 40 millimeter Hg. Moderate area of 1 to 1.5 centimeters square, pressure gradient 25 to 40 millimeter Hg. Mild aortic stenosis, area more than 1.5 centimeters square, and pressure gradient less than 25 millimeter of Hg or mercury. Now, how we manage it? Patients who are asymptomatic, remember asymptomatic severe aortic stenosis, We follow them up every 6 months or 12 months with echo, and we can do exercise testing to unmask symptoms or cause symptoms in the patient. Symptomatic severe aortic stenosis or left ventricular dysfunction. In that case, we need to do valve replacement, surgical or transcatheter aortic valve replacement, any of these options. They both have similar benefit as per the New England Journal of Medicine. Most surgeons, cardiac surgeons, prefer the transcatheter as it is minimally invasive, not as invasive as open surgery. Asymptomatic, if they are moderate, we monitor them with echo every 1 to 2 years, and we control risk factors like blood pressure, heart failure, etc. Uh, Medical therapy and stenosis of aortic valve hasn't been shown to give any benefit. It does not improve mortality. Instead, we need to focus on the comorbidities that are complicating the aortic stenosis. We have to avoid excessive afterload reduction. This can cause worsening symptoms instead of improving patient. Now, moving on to the next type of aortic valve disease, which is regurgitation. It is incompetent valve. The aortic valve is incompetent, is unable to hold the blood from entering the left ventricle back. This causes backflow to the left ventricle during diastole. Um, Commonly, it's caused by bicuspid valve, rheumatic disease, endocarditis, degenerative valve as in older age. Sometimes aortic root pathologies such as Marfan syndrome, blood pressure, hypertension, inflammation of aorta, syphilis, and chylosing spondylitis. These can also affect the aortic valve and cause regurgitation. Now, aortic regurgitation, it may present acutely with acute pulmonary edema, or it could be chronic. That would allow the left ventricle to adapt and patient will not have as many symptoms, but you may be able to hear the murmurs. Pathophysiology, in this case, since backflow is bringing more blood to the left ventricle, this is volume overload. This will cause eccentric left ventricular hypertrophy plus dilation. Patient will have high systolic blood pressure, low diastolic blood pressure, and widened pulse pressure. Compensation in aortic regurgitation. This allows left ventricle to adopt gradually, but if acutely aortic valve becomes regurgitant, then it causes acute decompensation when present with pulmonary edema. Now, it progresses over time if it's not managed. So left ventricle gets dilated and it can cause systolic dysfunction or heart failure with reduced ejection fraction. All right, let's move on to the next page. In aortic regurgitation, common symptom is fatigue and exertional dyspnea. We may see patient feeling palpitations, but if patient has acute regurgitation or worsening of regurgitation, they would present with orthopnea, acute decompensation, signs of heart failure. Clinically, you will see water hammer or collapsing pulse. Pulse pressure would be wide. If it is very severe and long-term, in those cases, you may see these rare signs like Demoset sign, which is head bobbing with systole. Auscultation of the chest would reveal diastolic decrescendo murmur at left sternal border. It's heard best if the patient is sitting like forward or leaning forward, and patient has already done their expiration or already blown air out of their mouth. Other signs, you may see pulsations in the capillaries, especially in the nails. Quincke sign, you would see hepatomegaly in acute settings. Now, we diagnose valvular disease like the other ones. This one would also be diagnosed by echo. It will give us the mechanism and the severity of why the regurgitation is happening, how bad it is. ECG will show left ventricular hypertrophy. Chest X-ray will show aortic root dilatation or cardiomyopathy. Now, In chronic cases, we manage it by medical therapy, ACE inhibitors, CCBs like amlodipine, um, if patient is symptomatic or dysfunction is present of left ventricle without surgery. For surgery, we need to have a indication. Indication is symptomatic severe or asymptomatic with left ventricular dysfunction or dilatation. Now, in cases of acute severe regurgitation, we can consider urgent surgery, but in order to prepare patient for surgery, give them vasodilators, inotropes, avoid beta blockers and blood pressure or medications that lower afterload. Mitral stenosis, it's common in people from countries where rheumatic heart disease is common. In exam, you may come across a question that explains a patient coming with a murmur or opening snap or similarly explained stem, and then they say patient has no past medical history, but they immigrated from another country to Canada or USA. Um, Definition once again, the valve is narrowed. Left atrium to left ventricle blood flow is obstructed or reduced during diastole when the valve, mitral valve is supposed to let blood into the left ventricle. Etiology, rheumatic heart disease, it's most common worldwide, and calcification can happen over time. Hemodynamically, left arterial pressure increases. This causes left arterial enlargement, which causes pulmonary venous congestion and pulmonary hypertension. Severity is based on um, valve area, mitral valve area. If it is 1.5 or less than that, then it becomes hemodynamically significant. Valve area of less than 1.0 or 1.0 is considered severe, and they usually require surgical treatment. So for mitral stenosis, the symptoms commonly they present with dyspnea. Usually it's exertional. It can over time evolve into orthopnea and pain deep. Hemoptysis is a symptom that can happen in mitral stenosis, and patient may get palpitations due to AFib. Some common complications with mitral stenosis are AFib, pulmonary hypertension, right ventricular failure, hoarseness, which is also called Ortner's sign. Now, for mitral valve stenosis, the murmur is a triad. It gives a triad of murmur. This one is loud. You hear an opening snap when the opens abruptly the mitral valve, and then you hear mid-diastolic rumble at the apex area. Right ventricular findings that may be present with mitral stenosis, especially if severe. If pulmonary hypertension develops, you may see right ventricular heave. E2 becomes loud. This indicates that there is increased pressure in pulmonary arteries. ECG for mitral valve stenosis, it will give us indication of left atrial enlargement, which is shown by white P wave, and you may find atrial fibrillation as it is common with mitral stenosis. Chest X-ray. Now, chest X-ray with mitral stenosis is interesting. The left heart border, it becomes straight because the atrium swells up or gets enlarged, and the ventricle is already supposed to be larger than the atrium. So instead of showing kind of like this, the left heart becomes straight. Um, this is something that you would see straight and left border. Pulmonary edema may be seen. Curly B lines there are also seen in pulmonary edema. Echo, this is diagnostic. We use echo to diagnose mitral valve pathologies. We look at valve area, pressure gradient, morphology of the valve or how it looks, the left atrial size, and presence of AFib, which we can also see on ECG. Now, management of mitral stenosis, we give them diuretics plus rate control or rhythm control and anticoagulation if AFib is present. Um, Treatment is percutaneous balloon valvotomy or surgical valve replacement in symptomatic patients. If they are symptomatic and moderate to severe mitral stenosis, you do surgical or balloon valvotomy. Mitral regurgitation, similarly, like we discussed in aortic regurgitation, mitral regurgitation is also mitral valve allowing backflow of blood, but in this case, it will be from the uh, left ventricle to the left atrium. Now, uh, primary mitral regurgitation, it's the pathology from within the valve leaflets, uh, like mitral valve prolapse, rheumatic disease, endocarditis, rupture of chordae tendineae, that it can happen in MIs. Secondary or functional regurgitation, this happens if there is left ventricular dilatation, such as in ischemic myopathies or cardiomyopathies or heart failure with reduced ejection fraction. Pathophysiology, volume overload on the left atrium. This causes dilatation of the left atrium and eventually left ventricle becomes dilated. The left ventricle hypertrophy is eccentric. Um, Chronic compensation and mitral regurgitation is common. Sometimes they can go into acute decompensation. In those cases, we will treat them as decompensated heart failure. Okay. Clinical features of mitral regurgitation, they present again with exertional dyspnea and fatigue. In acute cases of regurgitation, you will see pulmonary edema or shock. Murmur, you hear pansystolic murmur at the apex, and it radiates to the axilla. This one is soft, and P2 will be loud, and you may see pulmonary hypertension or pulmonary ridge pressure getting higher than it should be. Investigations again for mitral stent or regurgitation, echo. It's again investigation of choice. You can do ECG, it will give you evidence of left atrial enlargement, left ventricular hypertrophy, or AFib. Chest X-ray may show heart or cardiomegaly or pulmonary edema in acute cases. Now, how we treat patients with mitral regurgitation? If it is primary and symptomatic severe, we do surgical repair. This is preferred or replacement of valve. Asymptomatic with left ventricular dysfunction or dilatation, we still do surgery. Functional MR, that's usually due to heart failure or left ventricular hypertrophy. You optimize heart failure therapy with ACE inhibitor, beta blockers, diuretics. Uh, you can do transcatheter stage repair in some selected cases. Asymptomatic primary MR or mitral regurgitation. Observe if patient's ejection fraction is normal. Surgery if ejection fraction is between 50 or to 60%, or left ventricular end systolic diameter is more than 45 millimeter. Anticoagulation are given only if patient has AFib or and we give endocarditis prophylaxis like antibiotics if they're getting any routine blood work done, routine dental work or anything done. We give them antibiotics. Most likely, in most cases, it's a combination of amoxicillin and clavulanate. Now, this mitral valve prolapse, this is one cause of mitral regurgitation. The mitral leaflets, they bellow out or they fail during, or they kind of prolapse during systole. This causes them to go towards the left atrium, and you can see that on an echo if you're doing a parasternal long axis echo. Pathophysiology, the valve is myxomatous or swollen, there is degeneration, leaflet is redundant, and cords or chordae tendineae are elongated or ruptured. Most common cause of primary mitral regurgitation in developed countries. This is mitral valve prolapse. It affects 2 to 3% of the population. It could be either flail or kind of moving around, which is chordal rupture. Because of chordal rupture, this causes severe mitral regurgitation. Non-flail, this is usually mild to moderate or no mitral regurgitation. Now, management, if patient is asymptomatic, you just watch and wait, repeat, you can repeat echo. Symptomatic patient, they may get symptoms like atypical chest pain, palpitations, dyspnea, anxiety, dysautonomia, um, You can hear a murmur, which would be mid to late systolic click or late systolic murmur if regurgitation is present. Management, asymptomatic mitral valve prolapse without regurgitation, observation for 3 to 5 years. Symptomatic, beta blockers, severe regurgitation, surgical repair. Remember, surgical repair is almost always preserved for severe cases. Tricuspid stenosis, it's not very common, but can happen. Narrowing of tricuspid valve, right atrial to right ventricle is obstructed, blood flow is obstructed, or there is stenosis to it during diastole. Etiology could be rheumatic disease, commonly carcinoid syndrome, endocarditis, or congenital heart diseases. Hemodynamically, pressure in the right atrium increases. This causes hepatic congestion, ascites, and edema in the lower extremities. Um, this is very uncommon in isolation or alone, usually occurs with other diseases, especially mitral stenosis. For diagnosis, again, symptoms you may see dyspnea, fatigue, peripheral edema, hepatomegaly. You can hear a diastolic rumble at left lower sternal border or fourth intercostal space just next to the left of sternum. The murmur increases with inspiration. This is also called Carvalho sign. On examination, you may see JVP, and when you do JVP's measurement, you can see that the Y descent is prominent. It shows that the atrium is rapidly emptying. You may see hepatic pulsations. Investigations, echo, it gives us valve area and pressure gradient. ACG, it may give us right atrial enlargement signs or similar symptom findings. Right heart catheterization, if patient is in if the stenosis is hemodynamically significant. Uh, Now, management is usually medical. We give patient diuretics and try to find the underlying cause and treat that. Percutaneous intervention can be done. Balloon valvotomy is common if anatomy is suitable and patient is symptomatic. Surgical or open surgical treatment, tricuspid valve replacement. It's done in symptomatic severe tricuspid stenosis with right ventricular dysfunction or failed medical therapy. If we have combined lesions, so what we do is we manage it together with mitral valve surgery. We can consider same time replacement or repair of the tricuspid with the mitral valve if we are going to do surgical treatment for mitral valve. Regurgitation of the tricuspid, it's commonly due to the leaflet pathology, endocarditis, carcinoid degeneration, Epstein's anomaly, which can happen with lithium used during pregnancy, pacemaker complications, etc. It can also be secondary or functional regurgitation due to right ventricular dilatation from pulmonary HTN, left ventricular dysfunction, right ventricular infarction. Hemodynamics, this causes systolic backflow into the right atrium or inferior vena cava, which causes venous congestion, hepatomegaly, ascites, and peripheral edema. Severity-based mild tricuspid regurgitation, it's common, usually benign. Severe, it may cause right-sided heart failure symptoms such as peripheral edema, hepatojugular reflex, liver congestion, etc. Symptoms and signs in tricuspid regurgitation, once again, dyspnea, fatigue, weakness, these are common. Peripheral edema and ascites can happen. Hepatomegaly, liver being pulsatile, JVP increased with giant V waves. On auscultation, you will hear a pansystolic murmur at left lower sternal border. This will increase with inspiration, and S3 gallop, which signifies heart failure, can happen in severe cases. If right ventricle is enlarged, you would see right ventricular heave on palpation. Now, tricuspid regurgitation, how we diagnose it, how do we manage it? Mild cases are usually incidental. We don't do any treatment, they're benign. For investigations, we do echo. Echo will give us severity, size, function, everything. Chest X-ray may show cardiomegaly, pleural effusions, and ECG may show right ventricular enlargement signs. Moderate or to severe primary tricuspid regurgitation, usually we try to optimize patients' comorbidities and we consider surgical treatment if patient is getting worse despite medical therapy or symptoms are not improving. For functional regurgitation due to failure of the heart, we try to treat the underlying cause, such as pulmonary hypertension or the heart failure. We can consider um, tricuspid repair or annuloplasty with left-sided valve surgery, whichever is causing the symptoms. Pulmonic stenosis, once again, it's not common, but it can happen. Obstruction is from right ventricle to pulmonary artery during systole. Congenital stenosis is common. It can also happen in rheumatic disease, carcinoid syndrome, endocarditis, and calcifications. Congenital forms are usually isolated pulmonary stenosis, and it can happen in complex congenital disease such as tetralogy of Fallot, Noonan syndrome, etc. Now, hemodynamically, right ventricle's pressure gets increased. This causes right ventricular hypertrophy, and then that can progress to failure if going on for a while or severe. Um, Symptoms usually pulmonary stenosis is asymptomatic. Dyspnea, fatigue, cyanosis can occur if right ventricular failure happens. You may also see peripheral edema. On auscultation, you will hear systolic ejection murmur at left upper sternal border, which is also considered the pulmonary area. And S2 will be widely split. Right ventricular heave due to right ventricular hypertrophy. It may be palpable at the left sternal border if significant pulmonary stenosis. In severe cases, we'll see signs of right ventricular failure, such as peripheral edema, ascites, hepatomegaly, and you may see cyanosis in severe cases if there is a shunt present. Investigations, once again, echo is gold standard for it. ECG may show hypertrophy. Chest X-ray may show dilatation of pulmonary artery. Mild pulmonary stenosis, if the pressure gradient is more or less than 30, we deal with it conservatively. We don't start surgery or don't do surgery. Moderate to severe, we can consider percutaneous valvotomy, or we can go to surgery if anatomy is not allowing us. Now, some patients who are adult and they have a congenital heart disease, they usually present with exercise intolerance or restriction. Sometimes endocarditis may cause, sorry, we need to do endocarditis prophylaxis for this patient, and we need to counsel them on pregnancy to try and not get pregnant. Now, regurgitation of pulmonary valve, it allows backflow from the pulmonary artery to the right ventricle. Congenital anomalies, endocarditis, carcinoid tumor, rheumatic heart disease, secondary or functional regurgitation. It's due to pulmonary artery dilatation when there is pulmonary hypertension present or chronic right ventricular failure. Sometimes it can happen after repairing the heart for tetralogy of Fallot congenital heart disease. Mild is common and usually benign. There is no harm to patients, so we can leave it alone. Severe regurgitation, this can cause right ventricular overload and right ventricular failure, so we need to do surgical treatment for it. Once again, if it is mild, we leave it alone. Moderate to severe, you can hear early diastolic crescendo murmur at left sternal border, right ventricular volume overload signs like peripheral edema, ascites, etc. Symptoms can be vague like dyspnea, fatigue, palpitations, exercise intolerance. Management, we need to treat underlying pulmonary hypertension with ACE inhibitor, ARB pulmonary vasodilator such as phosphodiesterase inhibitors. Surgical treatment if right ventricular dysfunction or dilatation is present, and we have to monitor patients post-surgical repair for those undergoing tetralogy of Fallot repair. Okay, so key points. Stenosis causes pressure in the ventricle to go up or atrium. Regurgitation causes volume overload. So this causes pressure overload causes concentric hypertrophy, and volume overload causes eccentric hypertrophy. Um, Echo is gold standard for all valve pathology. Surgical indications, symptomatic or asymptomatic with ventricular dysfunction or severe dilatation. Regular monitoring, it's essential for asymptomatic, moderate to severe diseases to detect progression. Okay, and I think that's all.